today, which is a very interesting topic, underappreciated role of nutrition in diabetes management, an issue of belief of evidence. And for this particular topic, I invite speaker Dr. Arindam Naskar and chairpersons Dr. Mridul Bera, who is a founder of HDSS as well as a cardio-diabetic physician, and Dr. Kaushik Das, who is a consultant physician. I welcome chairpersons on the stage, and I would request Dr. Mridul Bera to introduce Dr. Arindam Naskar for all of us. Sir, would you kindly introduce the speaker for this session?
Now the topic is underappreciated role of nutrition in diabetes management, an issue of belief or evidence. The speaker is Dr. Arindam Naskar. He is an MRCP from UK and Edinburgh and is the regional faculty of CCEB DM course, that is PHFI, and his specialty is in endocrine and diabetes. I would like to call upon the speaker to the stage and give his opinion about the nutrition.
So thank you, Doctor, for your nice introduction, and I'm really grateful to the Howard Town Diabetes Society for giving the opportunity to share this topic. So today my topic of discussion will be on underappreciated role of nutrition in diabetes management, an issue of belief or evidence. In the topics of discussion, the topics will be role of nutrition in diabetes pathology and progression, guidelines on diabetes-specific nutrition, and need for diabetes-specific nutrition, impact on patient outcomes. And the diabetes mellitus current global range was over 537 million adults over there is a globe, and almost 1 in 2 patients of diabetes they have been underdiagnosed, and 3 in 4 adults with diabetes live in low and middle income countries. And more than 1.2 million children and adolescents are living with type 1 diabetes, and 1 in 6 life paths, which is quite important, are affected by diabetes during pregnancy. Factors contributing to diabetes, from in-utero nutrition to dietary intake. So starting from the mother's womb, there is the fetal programming of type 2 diabetes starts as a result of inadequate in-utero nutrition status. When there is disruption of normal fetal growth, and that may be caused by different factors like the maternal malnutrition, maternal stress, physical inactivity, maternal smoking, and maternal disorders like diabetes and the preeclampsia, the environmental exposure. So all this can cause there is disruption of epigenetic profile, and ultimately there will be changes in gene expressions that will cause the different disorders of the fetus. And the fetal programming and the adverse outcomes are there may be low birth weight, that may be due to there is impaired beta cell function, there is metabolic dysfunction, insulin resistant, obesity. So all these causes. So not only after the birth, when the baby is in mother's womb, it starts from there. Now the genetic factors have, there are different factors that are from the genetic factors have a really important role in onset of type 2 diabetes. The progressive phenotype is initiated by obesity and insulin resistance, which further develops with multiple metabolic organ dysfunction to culminate in diabetes mellitus. So progressive phenotype is very important that leads to type 2 diabetes. And the dietary components there, they are really important because they affect the gene expression in metabolic tissues and affect progression of type 2 diabetes mellitus. Different foods and diet like the flavonoids, vitamins, amino acids, fats, other compounds, they are involved in cell signaling and the metabolism, and there is differential gene expression, and that ultimately leads to the glucose homeostasis. And those nutrients that can affect those genetic expression either by direct effect or through their metabolites or through the signal transduction metabolism. And the vitamin gene interaction do have does the role of vitamin in inhibiting diabetes mellitus pathogenesis. Vitamins and nutrients with anti-diabetic properties by interaction with respective genes, they have a role in improving beta cell function. And you can see the slide that there are multiple vitamins like the vitamin D, they have functions, they reduce the insulitis. And next is the biotin, they increase the expression of certain genes like the FOXA2, increase PDX1, increase hepatocyte nuclear factor, 4-alpha, increase glucokinase, and increase voltage-mediated calcium channels in KSM, and that will ultimately cause an increase in insulin secretion and increase islet function. Next is riboflavin, they will increase the cytokine inflammation, decrease. And the nicotinamide increase the MAPA and they increase the insulin synthesis. So, vitamin gene interaction important role in inhibiting diabetic mellitus pathogenesis. And amino acids, what are their roles? Amino acids can improve insulin secretion and beta cell function via different gene interaction, and the most important is the leucine that will increase expression of the mTOR gene, and that will cause increased growth and proliferation of the beta cells. And the taurine causes that increased genetic expression of the sulfonylurea receptor 1, increased glucokinase, increased glucose transporter 2, increased insulin, and increased PDX1. And that will ultimately cause increased insulin synthesis, and there is increased insulin secretion. And L-glutamine, they will also can cause insulin secretion and proliferation. So vitamins and amino acids have very important role to play in expression of different genes. And the dietary nutrient deficiency has significant role in progression of diabetes. Most of the micronutrients are involved in the etiology of the chronic pathology. Diabetic mellitus complication increases in case of imbalance between the free radical formation and they are controlled by the natural antioxidants. Thus, antioxidant property of micronutrients are very much important, and multivitamin supplementation may be needed to address inadequacies or deficiencies in diabetic patients. And how this deficiency occurs in diabetic patients, there will be excessive urination and increased sweating, and there is increased losses of fluids from the body, and also increased metabolic demands for diabetic patients that will ultimately cause there is micronutrient deficiency and reduced plasma levels of micronutrient due to excessive losses to sweat or urination. Now, this is a slide showing how the long-term use of certain medications can induce clinically relevant micronutrient deficiency in your private chamber, in your clinics. Also, the proton pump inhibitor is one of the most commonly prescribed drugs that can cause vitamin B12, vitamin C deficiency, iron, calcium, magnesium, zinc, as well as beta carotene deficiency. Aspirin can cause vitamin C deficiency as well as iron deficiency, and the diabetes can cause the calcium, magnesium, thiamine, zinc, potassium, folate, zinc deficiency. And statin can cause vitamin D, vitamin E deficiency as well as coenzyme Q10. And the metformin, you all know that long-term prescriptions of metformin are associated with vitamin B12 as well as calcium deficiency. And the steroids and the selective steroid reacting inhibitors that can cause calcium as well as vitamin D deficiency. So diabetic patients, most of the diabetic patients, they have multiple comorbidities. Sometimes they are on prolonged therapy for other causes that can cause micronutrient deficiency in them. Now diet therapy in diabetes need to be redefined. What is the definition today? What is medical nutrition therapy? This is an interactive, collaborative and continuous process to modify nutrient intake involving the person with diabetes and his or her healthcare team. And what are the goals of MND? Different goals of MND to promote healthful eating patterns nutrient-dense food in proper portion size to improve overall health, to attain glycemic, blood pressure and lipid goals, to delay or prevent complications. Second is to address individual nutrition needs based on the personal and cultural preferences, health literacy and numeracy, access to healthful foods, willingness and ability to make behavioral changes. And third is to maintain the pleasure of eating by providing non-judgmental messages about food choices and limiting food choices only when indicated by scientific evidence. So unless there is scientific evidence, you should not ask him or her to stop these sorts of drugs or foods. And the next one is to provide an individual with diabetes the practical tools for developing healthy eating patterns instead of focusing on individual macronutrients, micronutrients or single food. So you should not focus on a single food or single macronutrients or micronutrients. So these are the major goals of MNT, medical nutrition therapy. And how do you classify MNT? Classify preventive diabetes, therapeutic MNT and the preventive MNT. Therapeutic for diabetes, suppose the patient has developed diabetes, so there is therapeutic MNT. And preventing patient with metabolic disorders and obesity or weight management. And how the MNT is classified according to the homemade and commercial is homemade and the commercial MNT that related to kidney other disease for diabetes control, for body weight loss and for specific nutrition deficiency. So this is the classification of MNT. Next is the classification of MNT method of use. How are you using the intensity, whether it's meal supplement or meal replacement. So according to the meal replacement, that may be complete replacement, partial replacement, complete followed by partial. And next is the mode of delivery. Usually it's internal form, oral feed or in rice tube by powder, bars or liquid shakes. Next is what is the role of MNT in managing diabetic patients. Clinical evidence suggests that patients with diabetes, they are receiving MNT achieve a 1 to 2%, that's quite significant, 1 to 2% reduction in HbA1c level, along with reduction in healthcare costs attributable to improvements in overall health outcomes and quality of life. So MNT plays a very important role in managing diabetes. Now what are the guidelines on diabetes, especially nutrition? According to the ADA, to promote and support healthful eating patterns, emphasizing a variety of nutrient-dense foods in order to improve overall health and body weight goals, to attain individualized glycemic, blood pressure and lipid goals, and to delay or prevent complications of diabetes. Number 2, to address individual nutrition needs based on personal and cultural preferences, health literacy and numeracy, access to healthful food choices, willingness and ability to make behavioral changes as well as barriers to change. And number 3, to maintain the pleasure of eating so that patient can enjoy his food by providing non-judgmental messages about food choices. And this is the ADA guideline for macronutrient. There is no definite guideline for percentage of carbohydrates. So low carbohydrate plants is not percent like 40%, 50%. So low carbohydrate plants may result in improved glycemia. Patients with diabetes should consume 20 to 35 grams of fiber from dietary intake. And what about fats? Currently they recommended limiting the amount of dietary saturated and trans fat intake. And proteins, a protein intake of 20 to 30% of total energy intake. And this is very important. It's like the RSSDI, the clinical practice recommendations of NNT of carbohydrates, fats, protein, and diet patterns. So carbohydrates, they are saying that carbohydrates should be 50 to 60% of the total calorie intake. Foods with a low glycemic index and glycemic load, rice quantity limited, and 25 to 40 grams of fibers should be taken per day. Next one for the fats, 30% of the total calorie intake should come from the fat. Oil rotation recommended, so patients should not be on single oil. So patient oil rotation like the sometimes mustard oil, sometimes maybe the olive oil, sometimes maybe the soybean oil. So oil rotation, because all the oils are important. You should not restrict to one oil. Next is the saturated fats should be less than 10% of total calorie intake, and avoid hydrogenated vegetable oils like the Gunuspati oils. Avoid the market. And what about the proteins? 15% of the total calorie intake should come from the proteins. Consider the other comorbidities like the renal failure and age. If the patient is having the renal insufficiency, then the protein intake should be lesser than the normal person. So ideally the protein intake should be the 1 gram per kg body weight, but in case of nephropathy, the protein intake should be 0.8 gram per kg of body weight. And diet rich in fruits, leafy vegetables, nuts, fibers, whole grains and unsaturated fat, that should be encouraged. Pulses, legumes, unprocessed vegetables and low fat diet. Salt consumption should be less than 5 gram per day and artificial sweeteners should be less than 2 to 3 gram per day. That is the recent RSSDI guidelines for MNT. And this is the slide showing the RSS, the different. I'll come to the next slide. The comparative is a very important slide. The ADA, RSSDI, ICMR and the consensus for nutrition of diabetes in Southeast Asia. These are the comparable chart. They are seeing according to the ADA there is no definite carbohydrate percentage mentioned, but the RSSDI 45 to 65% carbohydrate, ICMR 55 to 60%, and the recent government guideline in South Asia they are saying whatever carbohydrate the patient is taking, you should try to reduce by 10 to 15%. 10 to 15%. And the food should be high fiber intake. And what about the proteins? According to the ADA, the typically protein intake should be 15 to 20%, as I already mentioned. And its RSSDI and ICMR is 10 to 15%. And government guideline try to increase the current protein intake, whatever protein intake the patient is on, you have to increase by 10%. Next is the recommended intake of fats. No specified fat intake according to the ADA and RSSDI, but 20 to 25% according to ICMR, and government is trying to minimize the visible fat intake. And the same is the saturated fat intake should be less than 10%. Only the ICMR is suggesting the saturated fat intake should be less than 7%. And next one is, what about the Micronutrients Guideline? There is no specific recommendations made by the ADA for micronutrient guidelines as well as by the ICMR. But according to the RSSDI, inclusion of micronutrients like the alpha-lipoic acid, chromium, magnesium and zinc as adjunct to the standard care of diabetes. And comment, the Southeast Asian region, the comment is also recommending that ensure adequate micronutrient intake through diet and exogenous sources. So that all about the different guidelines in the sum. And the 7A of MNT, the 7 criteria should be the ideal MNT should be the 7 criteria that is accessible, acceptable, accurate, observable, affordable, attractive and appropriate. The 7 parameters of MNT, medical nutrition therapy. And now the diabetes specific nutrition formulas for diabetes management. These are the specialized forms of therapy that consist of macro and micronutrient ingredients to manage malnutrition, dysglycemia and other cardiometabolic risk factors, and have low glycemic indices component and complement dietary recommendations for patient with type 2 diabetes. That is the diabetes specific nutrition formulas. Now what are the different evidences? Saying theoretically is nothing important, you have to show evidences. So what are the different evidences? This is a pilot study. It's done not for very huge population, only 40 patients, 2 arms, 22 and 18. It's done by the Guwahati is called, and they show that when the diabetes specific nutrition formula has been compared to the standard formula, if you can see the graph, there is decreased postprandial blood glucose, and as well as there is decreased insulin response when compared to the standard formula. Next is there are multiple systemic analysis and the meta-analysis done, and they showed that diabetes specific nutrition is effective in reducing blood glucose level, and the average blood glucose level when compared to the standard formula is 1.15 millimole per liter, and those favors diabetes specific formula. And next is the same study. They showed that how they are effective in controlling glycemic hemoglobin, and average HbA1c reduction. They showed the 0.67% reduction of HbA1c when compared to the standard formula. And what about the HDL cholesterol level? When compared to the standard formula, diabetes specific nutrition formula, they are effective in increasing HDL cholesterol, and average HDL cholesterol they found in the standard meta-analysis. They showed that the 0.09 millimole per liter increase of HDL cholesterol when compared to the standard therapy. Now, this is a study done in Spanish ICUs with 153 patients, 2 years follow-up. They showed that in high-risk ICU patients, diabetes-specific formula lowered the insulin requirement. If you can see the graph, their insulin requirement is 23.7 in standard formula, while in 19.1 insulin requirement per day, those patients were on diabetes-specific formula. Also, the similar study showed that in high-risk ICU patients, DSM improved the glycemic control. So, if you can see the slide, significantly reduce the glycemic control in compared to standard formula. Next one is high-risk ICU patients. They followed for 2 years. They showed that diabetes-specific formula, they reduced the risk of infections. They reduced the tracheobronchitis incident rate as well as the ventilator-associated pneumonia when compared to the standard formula. So, diabetes-specific formula, they not only reduce the insulin dose, but they also reduce the infection rate in ICU. The impact of specialized nutrition on the glycemic variability. What their role is the glycemic variability. The effects of it, a total of 123 patients with type 2 diabetes are randomized to receive either lifestyle intervention together with the breakfast replacement with a liquid formula, or the lifestyle intervention alone for 4 weeks, and they completed the study. What they showed, if you can see the slide, that lifestyle intervention plus the meal replacement led to significantly better improvements in glycemic variability, because in all of the glycemic variability is very important, because if there is so much glycemic fluctuations, there may be more risk of developing complications. So, lifestyle intervention plus the meal replacement significantly better improvements in glycemic variability compared to the lifestyle intervention alone, suggesting that lifestyle intervention plus meal replacement would be an effective treatment to elevate glucose excursions. So, upper side you can see the gap, there is more glycemic variability. In the lower side, you can see there is almost the same with the black, the deep black line and the light black. So, there is less glycemic variability. And impact of specialized nutrition on the GLP-1 level. This is this study was compared in the consumption of the glycemic targeted specialized nutrition therapy, breakfast skipping, and the oatmeal. And they compared what are the GLP-1 responsibility in 3 arms. And they showed that they showed that the glycemic targeted specialized nutrition improved glycemic control and elevated GLP-1 levels compared to healthful breakfast food and breakfast skipping. So there is significant.
Quickly develop.
Just 2 slides. And you can see that in diabetes specific formulation, there is significant rise of GLP-1 levels when compared to the oatmeal and the skip breakfast. And the skip breakfast is not a very good concept. You can see the skip breakfast, there is the lowest increase of GLP-1 level. So diabetes specific formulation therapy followed by oatmeal and skip breakfast. Now, what are the take-home messages? I have already covered the DSM therapy. So various nutritional factors contribute to development and progression of diabetes, from inutile inadequate nutrition to dietary deficiency later life. Medical nutrition therapy plays a crucial role in achievement of optimal glycemic control. Guidelines recommend nutrition plans to individualized to meet the needs of patients with diabetes, and the specialized nutrition in diabetes management has been found beneficial impact on glycemic variability, weight, and avoiding hypoglycemia. So thank you all for your
Thank you, Dr. Naskar, for these wonderful presentations. Now, if you have any questions, I'll just take on up to questions.
Just one small question, Dr. Naskar, do you still advise to avoid red meat in diabetic patients? And if so, why?
Yeah, actually, red meat, according to the different guidelines, as red meat is saturated fat, so you should not take too much red meat. Okay, so according to the guidelines, the saturated food intake should be less than 7%. Or less than 10%, and we all know that red meat contains saturated fat. So it would be avoided as much as possible.
Thank you for the nice presentation. Actually, from the different studies and the different recommendations, it was evident that the balanced diet is mostly accepted. So there is slight differences in the protein, carbohydrate, fat and minerals. So I think there is no separate advice for this diet. And secondly, the usual questions by the patients are whether what type of carbohydrate we should eat. In India, especially in Bengal, whether rice, I shall skip the rice, I shall take roti or something, or I shall eat oat.
Yeah, actually the complex carbohydrates should be taken. That is the refined carbohydrates like the white rice, because the glycemic index is very much high. So you have to choose those sorts of carbohydrates. That is a complex carbohydrate, because complex carbohydrate will slowly reach the GLP level, and also the complex carbohydrate is preferable because it does not hit the glycemic level. So the brown rice is preferable than the white rice. And other like the pulses, the whole grain foods, the legumes, and the green leafy vegetables. So that should be taken.
Regarding the micronutrients, you mentioned that there is increased demand of the micronutrients because excess of sweating and excess of the urination. I practice sports medicine, and from the sports medicine for the players, we don't recommend any extra vitamin, extra mineral for good performance, because the total requirement per year is only 2 to 3 grams is micronutrients, and that requires no supplementation.
Yeah.
The daily diet, if it is proper and if it is contains the balanced diet along with the vegetables and fruits, no extra supplementation is required. What is required? What is your opinion?
Yeah, my opinion is that according to the American Diabetes Association, they are not recommending the routine use of multivitamins and other supplements. And you have to judge according to you. You have to look for what are the clinical features of any vitamin deficiency, like the angular stomatitis, the glossitis, the other features. So I should not recommend the routine use of multivitamins as well as antioxidants. So that is the individual basis. You have to see according to the patient, and sometimes it's been seen that it's 15 to almost 15% of patients who are on metformin therapy. Long-term metformin therapy can cause vitamin B12 deficiency. But definitely, ultimately you are the judge. You have to look for the signs and symptoms of vitamin deficiency, because the routine use of multivitamin and antioxidants are not recommended by any. So you have to judge by your own clinical eyes.
And also, I want to convey one message that for the players, we don't advise any food supplementation or the drinks, because the food supplementation, actually they are not required. If they consult proper dietitian and the consultant who is experienced in diet, slight changes in the diet can cover everything.
That's important.
And the risk factor is that the sports supplements, 25% of these sports supplements are adulterated with the doping material. So if the dietitian or the consultant treat a player, they should advise not to take the diet supplement.
So dietitian losing
So,
very important role here.
So with permission of the moderator, can I come in with the question with Dr. Bhattacharya?
yes, you can.
That's a very important question. Red meat. So I think this is a question which leads us to the basics of biochemistry. We all know about glycolysis. We all know about beta oxidation of fatty acids. Now, what happens when we have a good amount of saturated fatty acids? How is the intracellular absorption of fatty acids does take place? Is it through any receptor or gates? It is not through any receptor, it is not through any gates. It is basically through the diffusion through the BLP membrane. This we all know. We know glucose needs gates. Okay, we need the glucose we need the SGLT2s. Now when we have a preferential and sumptuous amount of free fatty acids in the blood, what happens? They will preferably diffuse into the cell. They will directly move into the mitochondria, and we know what happens in the mitochondria, that is beta oxidation of fatty acids. What are the end products of beta oxidation of fatty acids? Ketones, acetyl-CoA, and enormous amount of ATPs. Does the cell mitochondria require to undergo again glycolysis to produce ATPs? The cell already has. So what will happen is that because there is excess amount of ATPs and acetyl-CoA, the glycolysis process will be blocked. So if the glycolysis is blocked, the GLUT1 and the SGLT2s will be blocked, and the intracapillary blood glucose will. So this is the Ebert cycle.
Yeah, just I would like to comment that there is a diet of paleo diet. So the Periostation diet, that is the historical diet. যেখানে বলছে you should not restrict your diet. So protein, fat diet, you have to take the whole food, but should not take the processed food. So Paleolithian diet. Next diet is the keto diet. The keto diet concept is they are suggesting that you have to take the fatty meal at least 70 to 80%, carbohydrate less than 5%. That will promote the body weight loss as well as diabetic. But the thing is that if you take so much fats, there will be increased occurrence of urinary stones, as well as the cholesterol levels may be impaired. So that's why the keto diet is not very much popular. But regarding the paleo diet, they are recommending that you should take all the things, that red meat, there is no restriction on red meat. You should take all the foods, but without the processed foods. But the Mediterranean diet is the best diet they have studied. So at least 45 to 60% carbohydrate. But regarding Indian scenario, we are taking so much carbohydrate. If you go to the counterpart of Western country, they are taking most of proteins. So that's the person.
Dr. Naskar.
We Indians are consuming lot of palm oil, and it is used in processing food. So palm oil contains 40% palmitic acid. So what are the effect of palmitic acid on beta cells of pancreas and on cardiovascular disease? Because Western countries, they don't consume, European, they don't consume palm oil as a cooking media. They use for industrial use or moisturizing lotion or cream like that. But we are consuming as food palm oil.
Yeah, actually all the recommendations, they are suggesting that you have to rotate the oils, not only palm oil or mustard oil, because all the oils are beneficial because of the pupa component as well as the mupa component. So you have to maintain the ratio, because in Western population the ratio is 15 to 16:1, omega 3, omega 6. But the ideal recommendation is 5 to 6:1. So you have to rotate the oils, not only palm oil, soybean oil, or the olive oil.
Palm oil contains lot of saturated fat.
So saturated fats should not be recommended too much. The ideal saturated fat intake should be less than 10%. So you have to not only take the palm oils, because you have to extend the oils. Like some days mustard oil, some days sunflower oil, some days the rice bran oil. So you have to take like this.
Okay. If there is no questions, I will end up the session with I require one small comment from Srimanti. Srimanti is a dietitian and is attached to SAG. Srimanti, comment from your end.
Thank you so much, sir, because this is a very, very now kind of trending topic nowadays, that what should be consumed and how much should be consumed. So I believe in one strategy, that diet is not short term, it's a long term lifestyle change. So bringing that long-term lifestyle change, we have to eat portion controlled. We have to take everything depending on the individualistic point of view, and what we put on our plate, how much is the plate size and what time we eat, and also the stress factors, the amount of water and the amount of exercise throughout the day. Everything matters. So as a dietitian and now being attached with Sports Authority of India, I'm working with athletes currently. So there is a big difference in both the population. So there also I find that there's a huge drastic difference in both the population group. In athletes, the requirement goes really very high, where the portion controlling may not or may be required in certain cases. And for the special population cases, we have to be very specific in an individualistic goal. So this is what I believe, sir. Thank you for giving this opportunity.
There should be individualized, not
Absolutely.
like there should be individualized.
Thank you. Now, close the
Thank you,
session.
chairpersons. Thank you, speaker, sir. I will take a small moment for giving you the token of appreciation from our Diabetes Study Society. On the eve of Mahalaya, we are giving Ma Durga to you, sir. Thank you, speaker. Thank you, chairperson, sir. And thank you, Abbott, for sponsoring this particular session.